Great. Thank you, Augusto. I am very excited to introduce our next speaker to you. Anastacia Wall is a physician's assistant in our clinic here at the university. She is fantastic, and she has the task of telling us about the manifold different presentations and treatments of fatigue. Anything I can do to help? So this is your, okay, take your mouse to that guy, and then you should be all set. And that's forward, that's backward, and then the red one is the, yeah.
Well, thank you, Terry, Dr. Schreiner. It's very nice to be here. Again, my name's Anastacia Wall. I'm a physician assistant, and I work at the Rocky Mountain MS Center. I am absolutely thrilled to be here today with all of you who took the time on a Saturday to come out and learn more about this very important constellation of diseases. Before I start, usually when I'm interacting with people with transverse myelitis or Neuromyelitis Optica or MS, it's in a one-on-one or two-on-one situation. So it would just be helpful for me if I could understand, how many people, whether or not you have one of the demyelinating disorders, how many people in the room suffer from fatigue, at any point during their week. Okay. And then of those who raised your hand, how many of you, if you don't mind identifying yourself, suffer from a demyelinating illness? Okay. So as you can see, this is it's a pretty common word, fatigue. It's a common condition. It's one of the more common that present to primary care providers. And so I think some of the issues that come up for persons with demyelinating illness is how do I communicate this to my provider? How do I talk about it so that, because the issue is that this is a very important topic. I was thrilled to have the opportunity to speak on it because it's something that I talk a lot about with patients in the clinic. And it is one that I think is very disabling for patients, and it's one that they struggle with. There is no easy answer for this particular condition, and it affects their quality of life on a daily basis. So just to start, I just thought, first of all, I don't have any financial disclosures. The purpose of this talk here today was just to define fatigue. What is it that we're really referring to when we're talking about it? Understand what factors contribute to the experience of fatigue, to discuss what research has been done to better understand the underlying mechanisms that contribute to the disabling effects, and then discuss what the results of research into treatment options for neurological fatigue. So just to start, the classic medical definition of fatigue is a subjective, meaning the person's understanding or lack of physical and or mental energy that's perceived by the individual or caregiver to interfere with the usual and desired activities. And you can see that's a pretty broad definition and could apply to a lot of different things. So as clinicians or as researchers, as we try to understand this, we've tried to develop scales. One of the scales here is the fatigue severity scale, and it's been validated by research, and a lot of people will use this in their research to try to estimate where a person falls on the scale as far as mild, moderate, or severe. In this scale in particular, you have these 9 points in which the person would say, whether they disagree with this statement or they strongly agree with this statement, which would be a number 7. And then they're instructed to just choose a number that they feel represents them and their degree of agreement with that statement. And you can see that it's talking about, motivation being lower, that exercise brings on fatigue, that they're easily fatigued. It interferes with their ability to want to go places, do things, that it interferes with their ability to function in the workplace, at home, in a social element. So I like this scale because it doesn't, so people can be tired, but some people are still able to function. Some people are not able to function, that they could have no other symptoms, but their fatigue could be extremely disabling. And I think it's very hard for people to get attention for this complaint because it's such a common word that it's hard to really understand what it is that they're going through or how to address the situation. So I think it's important now with social media, we have the opportunity to talk to people and to hear from people and to hear their stories about what the experience is like. And so on this blog, Leanne Ryan writes 11 months after her initial attack, most days I'm so fatigued I can't keep my eyes open till 4 p.m. I'm learning to power nap around that time just to get me through cooking dinner and until bedtime because literally to just keep my eyes open. When you feel really tired, you feel tired, but this fatigue just takes over your body and you can't explain it till you feel it. I think I've become a power nap convert. I learned this technique and it works. This is my first week into it. I hope it keeps helping me get through each day. It gives me more time with my children in the evenings. That's precious and important. So, she has pain, she's exhausted, but she gets through each day living with life with transverse myelitis as best as she can for now. So, I think that this vignette illustrates how patients are suffering from this, and many times silently. I think, too, the experience is, they might say to another person, I have this fatigue, and they say, yeah, me too, and it's hard to separate out what it means to have a demyelinating illness and to have this fatigue versus what it means to have a tough day or to not get enough sleep that day before. Another way to explain it is many times, so if I get tired, if I rest, I will have recovery and I won't feel that fatigue anymore. When people have this sort of fatigue, a neurological fatigue, it isn't remedied by rest. They could rest and rest and rest and they never really feel any surge of energy or any recovery from that. So I think what's important to understand, so in MS, fatigue has been studied pretty extensively. In some of the other demyelinating disorders that are more rare, we don't have a lot of studies about it. But later in my talk, I will just go over a few studies that have been done that I think might be interesting to you to try to outline what might be unique or special about the various different demyelinating disorders. But because we have much overlap with multiple sclerosis, I thought it would be helpful just to outline what kinds of things or what we think about are the causes, primary and secondary factors to consider in fatigue and MS. So the primary factors are immune dysregulation, so changes in the neuroendocrine function. So you have a chemical pathway in the brain that is responsible for secreting chemical messengers to other parts of your body that stimulate various different hormones, okay? And so this is all a chemical process that's going on. And why wouldn't we think that if you have any demyelinating or change in the structure or scarring in the brain, that wouldn't affect those kinds of messengers as well? Other things would be central nervous system mechanisms, neuronal dysfunction due to immune injury, demyelination and inflammation, impaired innervation and activation of muscle groups leading to a compensatory increase in a central motor drive. Well, that's a very complicated sentence, but how I like to say it is, so when we put people into a functional MRI, and that's the one where if you're doing something or if they're having you perform a task, that part of your brain lights up because it's metabolizing more sugar than the other areas of the brain. And so what we see in people with MS is that when you put two people on a scanner, one in the who does not have MS, one who does have MS, and you have them just do a simple hand movement like this, you see the area around the hand in the person without MS as being right around the hand, kind of small, and it's representative of the action. But the person who has MS is recruiting an area like this. And so then for them, they're using more energy to do the same thing, which is why with the same activities of daily living, someone can look good, but yet go on to experience extreme fatigue even by 10 o'clock, by 4 o'clock in the afternoon. So the issue is that we don't totally understand. And there could be parts in the brain that aren't demyelinated on an MRI because, again, MRI does not show every single thing that's going on. The brain is the most complex structure, in the known universe. We have nothing that compares to it in its complexity. And so then to think that we are seeing everything on an MRI, we can't possibly. Other endocrine factors that we talked about a little bit earlier, just kind of expanding on that. And then also neurotransmitter dysregulation. You know, there's several neurotransmitters that we know really well. And the thing about the body is that it uses these in various different ways. You know, serotonin is used in the gut, it's used in the brain, it's used in a lot of different ways. It's also used for a lot of different purposes. So if we think that there could be dysregulation of that transmission, then those things can lead to a process of fatigue. Same thing with dopamine, with histamine, these pathways that could be found dysregulated as a result of demyelinating illness, and that could cause problems as well. So I think these, you know, where's my pointer? So these, you know, the top, the primary, those are things that have, through, you know, nothing that you can do has happened to you, right? So these are things that have happened as a result of a disease process. And science does not have the ability to go in and fix, you know, these sorts of things. So oftentimes in clinic, what we'll do is focus on things that are modifiable. So whereas I can't necessarily go in and you know, heal the damage from the past, what we can do is try to optimize all the different modifiable factors that could be going on in someone's life that could improve their outcome, that they may not even be thinking about. And so those are the things that represent these secondary factors. So one of the things is anybody who lays down for a period of time from illness, when they get up after a period of 3 days, will find that they are weaker. And that's just a process of physical deconditioning. So people who need to use chairs for ambulation will find that same sort of process happening for them. So one of the things is that they might see themselves getting weaker as a result of disuse. So the solution to that could be to get more exercise. Sleep dysfunction. This is one of my favorite topics, and I think one of the most ignored, because it could be sleep. I think one of the things is in the past, people didn't get 8 hours of sleep. Before the invention of the light bulb, people got 10 hours of sleep. And now we hear about people trying to get micro sleeps or 6 minutes of sleeps, or, we're just trying to cram more into life. And I think we're underestimating the power of the body to renew itself, to renew the chemistry. And if the sleep is dysregulated or there's dysfunction, then that can be also contributing to the daytime fatigue. There's some very nice studies that have looked at excessive daytime sleepiness versus physical fatigue or motor fatigability. And I have some studies later that I would show you that patients may not be the best indicators of if they have these sleep disorders because they're unconscious at the time. So I think that that's an important issue. Pain, as Dr. Mirabale described, is a very complex issue, and it can lead to problems in other areas as well. So then sensory disturbances, neuralgia, these things are exhausting. Just to live in pain all the time is exhausting. It just saps energy. And then to have to compensate for that by using all this energy, people could be done by, 2 o'clock. Depression, closely related to poor sleep, pain, and fatigue, can be an overlay. It is separate. So sometimes I think that people are kind of so I think that, the fatigue issue is a complicated one. So when it comes to mood, we know that when someone has depression, that one of the symptoms, besides sadness or feelings of guilt, are fatigue, is that there's this kind of a vegetative state that can happen when there's not enough chemistry in the brain to promote movement or mood. And so then we want to make sure, because this is modifiable, there are treatments for this, is a treatable disorder, that we're addressing that and eliminating that as a potential side effect. But what's also interesting is that when we've put people who have fatigue but don't have a mood disorder on a serotonin reuptake inhibitor, because of that neuroendocrine or neurotransmitter transition dysregulation, that actually they can improve in their area of fatigue. So sometimes when a provider is saying, well, let's try SSRI or something like that for your fatigue, they may not be saying it's because you have depression, or they may be saying let's treat the depression. But I think that the idea behind that would be let's make sure that whatever treatment is started, that eventually there's an outcome. So we want to make sure that whatever intervention is started, that there's a then follow-up, and is this going to be something that was effective or not? And then obviously medication. So these, the spinal cord is an area that's not very big, and when you have damage in there, it causes a constellation of symptoms that can include bladder and bowel and muscle and weakness. So then these are all things that have to be addressed. So spasticity agents like baclofen have side effects, and so we know that one of the side effects can be sedation. Pain medications can be very sedating. When you have a bladder that's causing urgency or the need to urinate at night, that's disrupting sleep. So whereas some medications can improve outcomes, they can have these side effects that overlay that we should also address, because obviously if I'm the one who's causing your fatigue, I wouldn't, and that's your main concern, and it may not be this other issue, then the medication should again be reviewed and making sure they're not just stacking up and actually causing some of the problems. Okay, so we talked about all of these things, but I also wanted to just talk about a couple other, which can be weakness. So when you have a weak limb and you're walking around and ambulating, it's taking more energy to do the same thing, to get the same places. And so then with a physical therapist or an occupational therapist, you can learn energy conservation techniques that can help to make you more efficient in your movements, or to how to organize your day, or maybe not go to IKEA, REI, and Costco all in the same day, So and then I think the other thing is what many experience is that if they have an infection, if they're going through grief, if they're having extreme stresses in their life, that can exacerbate the underlying conditions, and then they can find that they have worsening fatigue. One of the things that I think is so, I learn something from my patients every day, and I continue to honor it and think how important it is. But every day, not knowing what the day is going to bring, am I going to have the energy to be able to do what I want to do? And it's that unpredictability that I think can be very bothersome. So when it comes to infection or these kinds of things, we have to rule those factors out, because I think that it also can be very scary when you've had something happen and then you're feeling a worsening of those events. Is this a relapse? What is this? And to work with a provider to help to sort those issues out. Okay, so there's a lot of research, and I'm not going to go over each one of these in detail just due to the time. But honestly, there's some pretty cool stuff that's going on in the past couple of years as far as trying to understand what's underlying these things. So now we start to know that fatigue and MS, so this first study assessing pontine involvement using this new spectroscopy technology and MR, that we're now able to understand. Like I said, these MRIs are getting even cooler, like your smartphones. Every year your smartphone gets even cooler. Well, so do our MRIs. And now we're able to see things that we weren't able to see before. And fatigue, in particular, is becoming an area of interest, because it may be that is an early indicator of disease activity, and so that may be something that can be addressed, not just with another pill or another solution, but maybe with accelerating the disease-modifying therapy, or maybe getting another MRI, or maybe we need to look at something else that's going on. So what has been shown is that although they're able to do global studies now for atrophy in the brain, that it hasn't been the total brain atrophy that seems to be involved in fatigue. It seems to be that there are very focal areas of the brain that are associated with fatigue. They tend to be the frontal lobe, they tend to be the deep structures of the brain, and like the pons in the brain stem. And in these areas is where the reticular activating system is, which makes a lot of sense. That's the part of the brain that helps you to maintain consciousness. So when you fall asleep, there isn't a process in the brain that makes you fall asleep. It's the receding of this reticular activating system. And the medications that are used as stimulants are actually stimulating the reticular activating system. And so then there may be something going on there structurally that is causing some fatigue. But, again, these are, MS is something that affects the brain, and we're talking about diseases that talk about, the spinal cord. So what about them. So again, more information. There was a question earlier about Ampera in use in TM, and I looked for studies for that in particular, and I wasn't able to find anything as far as studies. So I think that that's an important area because I was surprised by that. It seems like that would be something, and that is being used, but that there's not any good studies that show outcome for that. But I did see that this medication has impact. So everybody focuses on the walking aspect of it, but actually this drug could be used in arms. It can be used in cognitive. It can be, and it's been shown. This one right here, sustained release effects on. Oops. Oh, hold on. Yep. Hold on. Here. Effects on the, motor and cognitive functions, mood, quality of life, so that there are more effects than just the 25-foot timed walk. And we see that in the clinic, and our patients describe that. And so I think that it is appropriate to use this drug in a more broad way. Another one would be how else can we study this drug? There have been, they tried it in peripheral neuropathy, so not central, but they tried it in people who have demyelinating, nerves that are outside of the central nervous system, and they didn't find that it was the same, which is likely due to the way that the action potential on the membrane, it's just different in the central nervous system than it is in the periphery. But there are some other interesting benefits I saw. So patients with optic neuropathy were tried on Ampera, and it found that they could improve their vision. So again, I think that there could be some novel and unique approaches with this medication, and if we can, then we should try it. But on the downside, with trigeminal neuralgia, like Dr. Miravalli was saying, it can actually potentiate trigeminal neuralgia. That was 5 patients who had been started on Ampera with MS, and 3 of them developed TN, a relapse. So I think that it should be used with caution. Okay, so in Neuromyelitis Optica, I wanted to talk a little bit about the types of studies that I reviewed in regards to fatigue. One of the things that I think is most important to consider that may not be is the incidence of restless legs and periodic movements in sleep, limb movements in sleep that occur with this particular disease. So that when studied, people who had no idea, so they just took people, anyone who had NMO, and they did sleep studies on them. And what they found that there was a high incidence of people that were waking up or were having difficulty or delayed onset of sleep due to issues that were causing them to either have jerking of their limbs or to have restless legs. And then what ends up happening is because you have these stages of sleep, you go into stage 1, you're unconscious, you don't know. You're going to stage 2. Now you're supposed to go into 3 and 4, but your leg starts jerking. So then it keeps bringing you down from that deep stage of restorative sleep back down to stage 2. You don't wake up all the way, but it's enough to keep you from getting very, very restorative sleep. So when you're having any issues of sleep or when you're having a lot of daytime fatigue, I think it's reasonable to expand that and not just take it as a given, this is just what I have to live with, but are there modifiable things that could be done? Because sleep studies are accessible, they're paid for, and there's treatments, so that would be one of the things that I just wanted to bring to you today. These other studies talk, and let me go ahead and take a question.
Yeah, so you were talking specifically about involuntary movements during sleep. My dad, who has TF, does this thing that we call dancing, where his feet just kind of like twitch while he's just sitting in his chair. So could involuntary movements like that happen during the day also contribute to that?
Well, what that does is that says that his risk of having them at night are very high because he's sitting there conscious and doing that. And that's a response from spasticity and possibly clonus, which are 2 separate things. But related. And certainly when people have that spasticity, they're at an increased risk to having these issues at night. And these studies really looked at that. Other things is that they found that when they treated depression in patients with NMO, that they improved their fatigue scores as well. So I think, again, that just says another issue to look at. So just for the end, and that final one was the study that I was telling you about, is that the underdiagnosis of sleep disorders in patients with MS, So, 4% of the population, of the male population, has sleep apnea. And sleep apnea is it is a completely under-recognized and totally treatable disorder, and it's non-invasive treatment as well, although you do have to sleep with a snorkel mask on your face. So it's not without anything, but I think that it's important to understand that there could be, like we were saying, this dysregulation inside the brain and with the chemistry, that there could be causing other problems like central sleep apnea or driving to breathe. And then during the day, that leads to cardiovascular risk, which we know when people get secondary medical issues. Most of my patients are very healthy. They just have these, the demyelinating illness. But then if they end up getting, cardiovascular disease, it increases their risk of developing disability. So we want to address these things. And when we're doing a good job and when we have a very educated patient population, we do.
I've never heard, so central sleep apnea and you later had ADEM. I've never heard those two things talked about at the same time. What brought those two up at the same? Is there any research to say they're linked?
Okay, so did I hear you say that they had the diagnosis of central sleep apnea and then before that's interesting. No, again, I didn't see any. I looked for ADEM in particular, and I didn't see that. I haven't seen that studied, but that is interesting, and but I can't speak to that. Okay, so obviously we don't have a lot of studies, but there are other conditions, like for example MS or poliomyelitis, where there are a significant amount of research, what I think we could potentially draw from, although we have to understand that these are unique situations that can they apply in this setting. And again, again with the periodic movements of sleep, that pain and fatigue, their impact on functioning. And then what are the novel approaches? So there was this one here, which is this transcranial direct current stimulation for sleep disturbances and fatigue. So it's this study down here. And what I like, so it was a positive study that indicated that there was improvement in patients that had this. And what it is it's basically this magnet that's put on the kind of surface and it's stimulating the brain. And this study, they were able to show that it was beneficial to people and that they were able to have better sleep, less pain, less fatigue. So I think it just says that there needs to be more research on this topic, and are there other non-pharmacologic approaches that we could be taking to and non-invasive approaches that could be very helpful for people. So I know that pediatric fatigue is also something that's because we always think of kids as like these bundles of energy, and it's like spend 5 minutes with my kids, they will totally wear you out. But we do know that when kids get demyelinating illness, that they do suffer from fatigue. And importantly, if it's not addressed, can impact their sense of self. It can impact their performance at school. It can impact their play with friends, which is their social development at a very crucial and important time. And so I just wanted to bring these studies to you that said that, interestingly, we think, pediatric transverse myelitis should not be associated with cognitive problems. But this study demonstrated that there were issues in these kids, and they had normal brain MRIs. And so I think so when we talk about the fatigue in transverse myelitis, could there be other things that that we just don't know about? That there could be other factors that are playing a role that are occurring in the brain that we just don't see. And then there are these studies, so the understanding fatigue and the factors that play a role in kids and how we need to address those, and that how fatigue or not being able to do the things that they wanted to do can lead to depression, and so that these can be co-occurring, but also one causing the other. And it's not necessarily I'm depressed, therefore I'm fatigued, but the fact that I'm not able to do the things that I'm doing is impacting me, and then also causing some depression as well. And so there are studies that are out there, and I just wanted to bring those to you. But again, I could do an entire talk just on each of these topics. So now I just want to shift over because I may never get a chance to see you in my clinic, and I just want to give you the best as far as how to advocate for yourself in terms of your clinic visit if you are suffering from fatigue, and how a clinician might think through these issues. So, this slide is just too small. But basically this says, Is fatigue present? Yes, no, okay, if possible. So if yes, then eliminate medications if possible, right? So that's the first thing. You don't want anybody doing anything to you that's making you fatigued if, like somebody had said, well, I have pain, but I can live with it. Well, then don't let a doctor put you on a med, because then that might cause side effects that then would be causing you more fatigue and actually decreasing your quality of life. So if yes, then is depression evident? If yes, then let's treat it. So then you treat it either with psychotherapy and or antidepressants. And then here we have the arrow keeping going on. It's still persisting. So assuming some people might drop out and have improvement. But then we get down to here. So now let's go to non-pharmacologic interventions. And those can include education, so that helping to understand, why am I feeling this way? Is there something wrong with me? Am I just, the society, we're so Calvinistic, and as far as our work ethic, and people get like, well, I should just do, and I'm not doing, and or concurrently their partner could be like, well, you're lazy, you're still in bed, and I think that can cause a lot of problems in relationships and with identity. And so then it's important that we also educate the caregivers, and we understand and that what they may be going through and how it's different than the fatigue that they're experiencing. That we talk about lifestyle modification. Again, a whole talk could just be done on the importance of diet. When we're eating really, really bad foods or high sugar foods, you're going to have that just natural crash that comes from that. To energy conservation and pacing strategies, not trying to do all the superstores in one day, or maybe it's just a few chores in one day. Work simplification strategies, so maybe simplifying life and not making things as complicated as they were. And then adaptive aids, cooling vests, things that could be helpful, like putting wheels on a laundry basket, just to decrease that, to use the cart when you're in the grocery store, just things like that can be helpful. And then if those things aren't helpful, then to consider medications. The ones that have been mostly studied have been amantadine and modafinil, which is Provigil or Nuvigil, and those have both been shown to be helpful in fatigue. But honestly, I really think that that's the last step. Until all of these are in place, until we've kind of done all of these things, you could put someone on a medication and it's not going to actually change their outcome. I think that we need to be addressing all of this and practicing good medicine before considering the medication. But I think the number one treatment in my mind is exercise. So there's multiple studies that have indicated that it really is counterintuitive, but I'm so tired, how could I possibly exercise? But like I said, we know that we can always get a muscle stronger, that we can always make sure that we are doing everything we can to help that. And one of the things that I thought was very interesting is this effects of intermittent versus continuous walking on distance and fatigue in persons with MS. So what they found was that if instead of walking the whole distance, if they stopped for a little bit, that they were able to go much further. And so these energy conservation techniques can be very effective in still meeting your goals and what you want to do, just doing it in a different way. So again, another patient's experience, this woman writes on the myelitis.org, when I started to work, I became stronger, was able to walk on my crutches for longer periods of time. I built up the core in my arms. Now I swim regularly. I kayak. I've learned to paraglide. I also fly my power kite. A big part of my rehabilitation was acceptance. Unless you strip it back to the beginning and accept the person that you've become, you can't move on with your life. So again, I've kind of run out of time, and I'm happy to talk to you after. But there are a number of medications that can be used. This is things that you would know about, so there isn't anything. I just did want to talk about this real quick, is that this is a new and kind of novel approach, is that now we're starting to understand this gut microbiota brain axis, and they're studying it in neuropsychiatric disorders. They also found that patients with MS had a different microbiota than patients without it, and that those were treated had different than those were not. I think it's a very interesting point. The treatment that they're looking at is fecal transplant, so I may be talking about that next year. You never know. So oftentimes people want to know, what can I take other than medications? And you can see here that as far as what's safe and what's effective in the natural medications, we don't have anything. And so then these are the things that are likely safe but may be effective, and then it just kind of goes down here. And in the red are the things that aren't safe and aren't effective. So take that as it is. So unfortunately, we don't really have a good way other than exercise. Okay, so just to end, I just wanted to put a little plug out there. I'm really excited for the Paralympics in Rio 2016. It'll be there September 7th through 18th. Obviously, these people, are heroes. My personal heroes are the patients and the caregivers that I see whose stories will never be told, who live with this on a daily basis. But I do draw inspiration from these kinds of people. And this is just a short list of the people who have transverse myelitis who will be participating in the games this year. So thank you again for your attention and your time. Again, appreciate the opportunity to speak, and I'll end there.